We're getting close to noon, so I'm going to go ahead and start recording so I don't forget to do that. And we will give folks just another minute and then we will get started. Well, thank you all so much for joining us today for the Youth Suicide Prevention Store It Safe Quality Improvement Project Learning Session. We're really grateful for all the practices that are going to be working with us on this project. And we also want to thank the Ohio Department of Health and Ohio Mental Health and Addiction Services and our colleagues at the Ohio Academy of Family Physicians. We're all working together with you on the project. You may not see or be introduced to all of the folks who are working on this, but I want to assure you there are so many resources available to you with questions and support as we work through the project and learn so much together. So today we are going to do just brief introductions of our core project team. And then Dr. Denny is actually going to kick us off with a talk about screening for depression and suicidality and using the Ohio AAP resources. She may need to leave us a bit early today, so we wanted to have her go first so we had plenty of time for her talk and questions. And then we're going to do a brief practice introductions with those sort of pre-questions that I asked you to think about for today. And then I'll give you just a quick overview again of some program requirements and next steps. Also today, we don't have as many folks as we would have like on a webinar. So we want this to be more informal. Feel free if you have a question or something to clarify to unmute yourself and ask. Also, feel free to use the chat box. We will be monitoring that. So with that, I wanted us to give some brief introductions. I've already talked with most of you with our kickoff meeting, but I'm Kristen Fluitt. I'm the Senior Quality Manager here at the chapter, and I'm the project manager for Store It Safe. I am, to answer the question that we asked all of you to talk about, why you wanted to do this project. I was so excited to be selected to be the program manager for this project because behavioral health is sort of my passion area. I've been a direct care clinician in behavioral health, and it's a lot of the work that I did before I came to the Ohio AAP. So I was really excited to be working on this again. And I also know when I was a clinician, working closely with primary care providers just enriched kind of my work and obviously the progress that patients would make. So I'm very excited to work with all of you, and it's been wonderful getting to chat and meet all of you as we've done kickoff meetings. So with that, I wanted to turn it over to Dr. Gittleman to do a brief introduction and talk about why this work is so important to him.
My name is Mike Gittleman. I'm an ER physician at Cincinnati Children's Hospital. I run a lot of the Ohio AAP injury programs with Sarah, and I'm passionate about this for twofold. One is that I think firearm safety is essential, and this is one way to get about preventing firearm injuries. And then the other is that the problem of mental health has really been increasing in our society. We see significant numbers of that in our emergency department, and ways for us to be able to screen and get kids into care sooner, I think, is essential. And so I'm really thankful for all of you being a part of this program.
Thank you. And Dr. Denny?
Sure. My name is Sarah Denny. I'm a primary care pediatrician at Nationwide Children's. I've been in primary care for the past 3 years, and before that worked in the emergency room at Children's. So kind of have both sides of this experience. I do a lot of work, as Mike said, with injury prevention. I also do a lot of policy work. And I'm a mom of teens. So this connects to me in a lot of different ways.
Great. Thank you. So Dr. Denny, I will turn it over to you, and I will just say next slide, and I'll advance the slides for you.
Great. Thanks, Kristen. Well, thank you guys all for joining us. And thank you to our funders for really kind of pushing this forward on how important this is. I'm not going to go into a ton of background information, because at this point you've already watched the video for your pre-work, and many of you have watched the webinar, and I didn't want to make it too redundant to those. But if you didn't get a chance to watch those things, that might give you a little bit of background. So I'm going to spend a little bit of time talking about the why and a lot more of the time talking about the how. Next slide, please. So just to level set, make sure we're all on the same page about why this is so important. Suicide has become the second leading cause of death in people 10 to 25 years old in the United States. And as Mike said, these rates are continuing to rise. During my experience in the ER, and I'm sure I've heard Mike attest to this as well, that we keep seeing an increase in ER visits. And so this was just published. An increase, the authors of this study found an increase in ED visits in adolescents 12 to 17 for suicide attempts increased by 31% just last year. So we know this is going up, and the pandemic certainly did not help. Next slide, please. Okay, so again, this probably isn't a surprise to anyone. Obviously, you guys are interested in this area and probably have some background experience and knowledge, but household gun access triples the risk of death by suicide. We know when we look at youth who have completed suicide by firearm, 82% used a gun from their own home. Next slide, please. This is probably familiar to you. It was recently published in the New England Journal of Medicine, and I included this really to show you that for the first time in 20 years, firearm-related injury has increased the cause of death, surpassing motor vehicle crashes. So for the longest time, we were talking about motor vehicle crashes. We probably all talk about seatbelt use and car seats and booster seats, and that's still really, really important. And we're doing a great job, as you can tell from this data. But we're now starting to see firearm-related injuries surpass that. So it just speaks to the importance of this program, but really Store It Safe in general. For this particular learning collaborative and phase of Store It Safe, we're talking about adolescent suicide, adolescent and young adult suicide, I should say. But we also have the Store It Safe program for young children, where we see more of the accidental shootings in children. Next slide, please. So when we look at data around people who have attempted suicide, of the survivors, 50% of those surveyed in this particular study said that they made an attempt within 20 minutes of their decision to attempt suicide. 25% made an attempt within 5 minutes of the decision, and 71% of the survivors made an attempt within an hour of their decision to attempt suicide. So what we know is that first hour after the decision to attempt suicide is critical in restricting access to lethal means, to kind of give them, past that 1 hour mark, to really get on the other side of the crisis that they're experiencing. So we know that really time is of the essence, and anything we can do to delay their access can really save a life. Next slide, please. So, we're not just talking about firearms here. Now, we do know that, if you're attempting suicide by firearms, then the rate of completion is much higher. But we're talking about all lethal means. So we're talking about medications, even Tylenol, right? I mean, I'm sure we've all taken care of someone in our career who tried to overdose on Tylenol and has really, if it's not fatal, it has some potential really long life-lasting effects. So barriers to lethal means is very effective in reducing suicide because it buys you time, right? It gets you through that hour, gets you through that acute crisis to a place where you can start, having hope, looking for the future, reaching out, using your coping mechanisms, all of those things. The other thing that I really want everyone to take away from our entire conversation today is we're not just talking about having access around reducing access to lethal means in families where the child has a history of mental health concerns or history of depression, history of a suicide attempt. This is a conversation that should be happening in all adolescents, whether they've had an attempt, not had an attempt. If everything's going great all the time, great, but we still need to be having these conversations. Next slide, please. So if you're not familiar with this blueprint for youth suicide prevention, I would really, really encourage you to spend a little bit of time. If you just Google search like American Academy of Pediatrics Blueprint for Suicide Prevention, you will find this. It is a fantastic resource. I'm sure that almost every single question you can think of is probably somewhere in this amazing document. But I wanted to pull out this one piece that I've included on the slide here that says health clinicians are well positioned to identify and support youth at risk for suicide in any type of clinical setting. And how do we do that? Number one, universal screening. Great. That's what we're here to talk about today. We're going to start universal screening. Two, standardized clinical pathways. That's another piece of this learning collaborative. And then leveraging the strengths of all members of the care team. So, this isn't just a nurse thing. This isn't just a doctor thing. This is your social work. This is your mental health professionals. Like the whole team is involved in this process. Next slide, please. Just as a reminder of how important healthcare providers are in relation to this screening, we know from looking back from studies, when we look back at healthcare contacts prior to a suicide death, 80% of adolescents had visited their healthcare provider in the year prior to their death. 49% had visited the ER within a year of their death. 38% had some sort of contact with the healthcare system within the 4 weeks before their death. And then 34% of people ages 15 and up had contact with their healthcare provider in the week before their death. But we're not going to know if our families or our patients are suicidal if we're not asking. And so that's one of the key pieces that we're really talking about today. Next slide, please. So I think that it is pretty standard practice at this point to be screening for depression at well child visits. But one question I get asked a lot is, well, I'm screening for depression, so is that good enough? No, it is not good enough. It's really, really good for screening for depression, but not all people who are suicidal are depressed. And so we know that when we're using the PHQ-9A, which is really good for depression screening, we can miss up to 36% of pediatric patients who do screen positive for a suicide risk. So that second screen for suicidality is totally different. So, we're screening for depression, but we also have to screen for suicidality. They're not the same thing. Next slide, please. So this is specifically regarding suicide screening and what the recommendations are for youth in particular. So the American Academy of Pediatrics recommends that we're screening all youth ages 12 and up. So universal screening. That means if they're coming in for a sports physical, we're screening. If they're coming in for a mood check, then obviously we're screening. But we're not just screening kids who have a history of mental health problems. We're screening at every preventative well child visit or sports physical. 8 to 11 is more clinician dependent as far as when you think that it might be clinically indicated. And then screening's not recommended in kids under 8, but obviously if you have concerns for suicidality, that should definitely most certainly be addressed. Next slide. Okay, so another great resource, and I put the links in for both these resources, the blueprint and then the Ask toolkit. I'm specifically referring to Ask because that's what I use. And so that's the one I'm most familiar with. Ask stands for Ask Suicide Screening Questions. And there is a fantastic toolkit available to providers who are interested in using this. And that's where I got this infographic. But basically, it breaks down, what is the process for assessing for suicidality. The first is a brief screen. The Ask is a 5-question questionnaire. It takes less than 20 seconds for the adolescent or young adult to complete. If it's negative, then that's fine. If there's any positives, then you move on to the assessment. So you screen, then if indicated, you assess, and that's about 10 minutes. And that can be, your social worker, nurse practitioner, PA, a physician, your mental health clinician. It's not just one particular kind of provider that can do that brief suicide safety assessment. If they come back low risk, then we want to do a safety plan. And depending on what you think is indicated, plus or minus a mental health referral. If the assessment indicates that there's further evaluation needed, then we do the mental health referral, we do the safety plan, and then we do really close follow-up. We're talking like 2 to 3 days. And then obviously, if you do the assessment and it's imminent risk, then you get a one-to-one sitter and they go to the emergency department with all the safety precautions. I will also just add, I know I work in a clinic where most of my families are not English speaking. If you go to the Ask website, they are in 15 different languages. So I would definitely encourage you to check that out and see what fits your practice's needs. Next slide, please. Okay, so this is in your resources, and there's a lot on the slide, so I'm sorry, we're going to break it down. So don't look at this and start trying to read it all. It's fine, but I just wanted to show you that we kind of have an example pathway. One of the things with learning collaboratives that we've learned is we don't want to be too prescriptive. I mean, we know what components we need to have to make this successful, but how it works in your practice, that's going to be up to you. And you guys, as your team that you've identified in your work group, it will really have to kind of spend a little bit of time about what makes the most sense. We'll go to the next slide, please. So just taking the top chunk of that flow sheet, we're doing for this learning collaborative, and your materials will be adjusted ages 12 to 21. So we'll make those adjustments, but they come for their well child visit. You're going to screen for depression using a recommended screening tool. You're going to screen also for suicidality using a recommended screening tool. For all patients, we're still going to talk about suicide risk and restriction of access to lethal means and safe storage. And we're providing these resources to the family and then offering safety box or safety locks. So again, we're not just having this discussion with kids who flag as potentially depressed or potentially suicidal. This is really a conversation for all families. And, I think that starting that conversation in the exam room is really helpful and helps empower the parents to keep that line of communication open and continue that discussion at home, because it's not a one and done, right? Like it's something that you need to continue to check in and do these check-ins as stresses in the adolescent's life change and evolve. We also actually, resources that you're going to get also that I think are very helpful is the family discussion guide. Sometimes this can be difficult for families to talk about. The youth suicide rat card, and I will add that we did this in partnership with many youth. So this has been put together and vetted through our youth advisors. And then also the crisis planning rack card. We know that in the middle of a crisis is not the time to come up with a crisis plan. We want to do that in advance. And Dr. Harris did a fantastic job during the webinar talking about a safety plan. So if you didn't get a chance to see that, I would refer you back to that, because she went over, how and when you develop a safety plan. Okay, next slide, please. Great. This is, again, another resource for you talking about how do you have this conversation? So the back side of this paper is what we are going over right now, the algorithm, but the front side is about screening, which we're talking about, intervening, and then seeking treatment as indicated. Some providers feel uncomfortable about talking about guns or lethal means. But if we're talking about safety, and it's what we do, right, as healthcare providers during anticipatory guidance, we talk about swim lessons, we talk about car seats, we talk about smoking in our adolescents, if we just incorporate that into the safety talk, it really lends itself to kind of easing into that discussion. As I mentioned on the webinar, they've done studies with focus groups of parents, and they do want to have these conversations with their healthcare providers. Next slide. Okay, so this is again kind of zooming in down on one branch of that algorithm that we showed earlier. So we're screening for depression, and then you have to do something, right, with the screening results. That's always the thing about screening is, okay, then what do I do? Obviously, if it's everyone probably has experience in treating depression. So I'm not going to go down a rabbit hole getting too deep in the nitty-gritty of depression treatment. But this is just sort of some suggested thoughts if you don't already have a systematic process in place. Mild depression and no acute lethality concerns, obviously you're going to provide resources, focus on strengths, right? Focusing on those positives and then follow up as needed. In the moderate to high risk, but again, no lethality concerns, you're going to, do what's appropriate for your clinical setting, whether you think medication is appropriate at that time, referral to a mental health specialist. Again, you're doing safety planning, and then you want that close follow-up. Next slide. And then when we talk about suicidality, one of the things when you look at that ask questionnaire is 1 through 4. If they answer yes to 1 through 4, but no to question 5, then you need to do your assessment, right? You need to do your suicidality assessment, develop a follow-up plan, do a safety plan, refer for mental health services. If the answer to question 5 is yes, then you need to get a one-to-one person in there for a sitter and then do a supervised transport to the emergency room. So if you get a yes for a question on the ask, that does not necessarily mean go to the ER. If it's yes to question 5. So I think, the data that I mentioned at the very beginning support the fact that our ERs are overwhelmed by patients going to the ER. So I think that one of the purposes that we're trying to do here is sort of walk through what the process looks like instead of sending a family to the emergency room where they're going to wait for like hours, days, maybe even, and then get sent home with nothing. Is how can we more effectively link them with resources while still keeping the child safe? Next slide. Okay, so coding, that's always another big issue or question, I should say. So if you're screening with the PHQ-9A, you're going to put in your code for a screening tool or your brief emotional behavioral assessment. If you're also doing the ask, then you're going to list that separately, okay, as a different line because it's a separate standardized instrument. And then you're going to use a modifier. So for me, I use the 59 modifier. I would encourage you to look into, what your health system or what your payers prefer. But that's how I code that on every adolescent well child visit, sports physical, mood check. Also we sometimes, if we were really worried about, and I'm already going beyond the scope of this call, but, we'll use the GAD-7. That would go as another one. I'd list that one separately as well if I'm worried about anxiety and wanting to take a look at that. Next slide. So these are the links to the 2 resources that I'm mentioned. Now, obviously, you already have the Store It Safe resources, so that's great, and you know how to access those easily. But I did want to provide you the links to the blueprint for youth suicide prevention, as well as the Ask Toolkit, because I think they're very, very helpful. And they really get into the nitty gritty of, okay, what do I do if this, or what do I do when this happens? So I just encourage you, it's really well written. There's also some policy stuff or advocacy things that they call out of ways that we can advocate for mental health services for our youth. So I'm going to just take a minute here. I can't see the chat. So Kristen, I'm going to count on you, but either unmute yourself to ask questions, put it in the chat, and I will do my very best to answer.
I was going to say, please feel free to unmute yourself. We have a bit more time before Dr. Denny has to leave us. So any questions that you have, please feel free to ask those or chat them in. If you have any trouble unmuting yourself, I think you can raise your hand and I could unmute you. So far, I haven't seen questions in the chat come up yet, Dr. Denny.
Yeah, so I, while you're thinking of kind of like what does this look like implementing in your practice, I'll just share how we do it in ours. Obviously, the adolescent or the young adult should be answering these in privacy, not with their parents. So how we do it in our clinic is the family is roomed, and then when the child goes out of the room for weight and vitals, they're given an iPad where they complete these questions, and then that goes right into my EMR. So I am able to pull it up. I usually pull it up before I go into the room, so I have a plan of whether or not I'm going to bring up the fact that I need to bring in a mental health specialist, whether it's our social worker or psychologist, and whether or not they're going to be coming in, or what kind of plan I want to have going into the into the visit. So that's how we do that. I have stored safe resources in all of my rooms, and it just is a really great way to kind of start that conversation about having regular check-ins as a family and restricting access to lethal means and coming up with a plan before there's a crisis. So it's a really nice way to kind of segue into that. And I also think it just really opens the door for my adolescents to know that, you know, this is something you can talk about. This is a safe space. And maybe it's not relevant at this visit, but maybe 2 visits from now, it really is relevant. And we've already touched on it, and we've already kind of laid some foundation for that conversation.
Hi, this is Jennifer Bacci from University Hospitals. Can you hear me?
Yeah, sure can.
Hi there. Such a wonderful program. I just want to start with that, which is why we're participating. But my question is on resources for the practices, you know, the stored safe resources. So once we're done with this pilot, which I believe is going through like the end of February, how do the practices continue to get those resources for patients?
So those resources are going to be available to you on a website, and you will continue to have access to them. There will be QR codes given to you that won't, change. So you may have something posted in your rooms or out in your waiting room, directing folks to scan those to have access to the resources. So those will continue to be available.
That's wonderful. And what about the safety boxes?
Okay, so the safety boxes we will be ending when the project ends in February, but we do tend to have some programs where you may be able to apply for additional ones. We would recommend that the stipend that clinics are getting, you may be able to use those for additional ones when it's over. And then we also suggest, particularly if you are in larger institution settings, that if we can help with anything from the project, demonstrate the outcomes of the work, that sometimes you're able in your own institution to start something where you can continue to have access to those.
Yeah, I would just add on to that. We piloted something, and then our hospital has an ACO. And so the ACO was really interested in our work. And so now they have purchased gun boxes and are handing them out through all of their practices. So I definitely would say within the larger hospital systems is, partnering with your behavioral health specialist, which really, I should have said at the very beginning, is important when you are trying to think, come up with resources for your families, who within your hospital system, but, hospital systems are really overwhelmed too. So we also have, we've made partnerships with other community groups that provide counseling, or, Directions for Youth, for example, who comes in and does work within the school. So I don't have to worry about the kid getting a ride to counseling. I just know he's going to get counseling when he goes to school. So definitely, I would encourage you guys to be out in the community and building partnerships, because that'll help get your kids linked, depending on what their circumstances are and what their needs are.
Okay, thank you.
Any additional questions at this point for Dr. Denny?
Well, I just want to say big thanks to all of you. And we're recording this. I'm really looking forward to hearing what your why is and what motivated you. I mean, you've got 1,000 opportunities for MOC and QI work, but you chose this, which I think is great for you guys, but I also think it's even better for your patients. And I'm just really excited to learn more about what brought you to this project. And we're super excited to have you on board.
Great. Thank you so much, Dr. Denny.
Okay.
So we wanted to just take some time for you to introduce yourselves, who I know we don't have all members necessarily of your team on the phone, but whomever is on the phone representing your practice. And I had sent out kind of these couple of questions that we wanted to hear from you about, which is what led you to choose, what led your practice to choose to do this project? something in your personal or professional life that drew you to this work? And then at the end of the project, what do you hope to have accomplished? So I'm just going to go down the list. We did have, like I mentioned, a couple of new practices, so they may not be on the line with us today, but I'll follow up with them as well and share their response to this question with all of you. So who do we have on the line from Pediatric Associates of Mount Carmel?
Hi, Kristen. It's Jasmine, the office manager, and MJ, our front office coordinator.
Hi, thank you both for joining us. So if you wouldn't mind to answer those questions for us.
Yeah, so we chose this project because we felt gun safety is a huge issue in our country, and that our doctors felt this project will be beneficial to our patients and families, even if we can make a small difference.
And then the second part was just at the end. What does your practice hope to have accomplished?
So our goal is that even when the project itself at the end of February 2023, that these discussions will become part of like the doctor's routine, and that they will continue to have them and continue to provide those resources for the families.
Great, thank you so much. Children's Anderson Primary Care.
It's Dr. Kerwin. So I'm interested, I got us interested in this project because we have been part of Children's in a relatively short period of time. And since in that 2 years, we've been doing depression screening at all the checkups for 12 and up. And we do some suicide screening, not routinely, but I'm interested in that piece too. And I just kind of want to answer the question, now what? Because, you know, we're finding kids that are thinking about it, finding a lot of kids thinking about it. And it's so like, we have a behavioral health specialist in the office, but it seems like my depressed kids always come in at the end of the day when she's not here. And so now what? And so I want to answer that question. And I'm hoping by the end of February that all of the providers in the practice will have an answer to now what and be comfortable with talking about restricting lethal means.
Great, thank you so much. Associated Pediatrics.
Yeah, hi, this is Brad Fuller. I'm one of the pediatricians. I was interested in this project really for the reason that was shown in Dr. Denny's first couple slides there, just because this is one of the leading causes of death in our patients. And, you know, especially knowing the public health crisis that gun violence is in this country, you know, whatever we can do to help with that, I think is important. And then by the end of it, I just hope that, you know, screening for suicidality and, you know, having these conversations is just a routine part of our checkups.
Great, thank you. Fairfield Primary Care.
Hi, I'm Jennifer Hardy. I'm a big QI collaborative junkie. I just feel like any time that I'm not hanging out with Kristen and Haley is just a sad time in my life. So they just do such a fantastic job, and we always end up learning a lot from them. We've been trying at Fairfield, we're part of Cincinnati Children's, but we're trying to really sort of move discussion of adolescent mental health and means reduction from any sort of like stigma as just being a very routine part of care. Mm-hmm. And so we always talk to our team members that, you know, teenagers are really the same as toddlers. They you know, they have no impulse control. They listen to the same music over and over. They put everything in their mouth. So just like we would talk about using cabinet locks for a little kid, we need to talk about lock boxes for the big kids. And just like we have our behavior specialists talk about tantrums and toilet training. Now we've got our behavior specialists talking about, you know, screen time and sleep and things they can do to build resiliency and like seeking help when they need it. So this is a great way for us to be able to kind of expand that, because we haven't been doing the ask, just the PHQ-9. So we're looking forward to trying that out and seeing how that's going to help with that.
Right, and to let you all know, Dr. Hardy did participate in a pilot project for this work. So we're really happy to have her because she's got a lot of experience and can share a lot of, you know, hands-on learning and knowledge. So thank you again for joining us, Dr. Hardy. And then Medina Family and Internal Medicine and Pediatrics.
Hi, it's Dr. Hummel. So I participated in a QI project with you guys a couple years ago. So I get these reminders. And when I saw this one, I thought it looked like a really worthwhile project. And we do We do the PHQ-9 for adults. We're a family practice, so I do internal medicine and pediatrics. My partner's a family practice doctor, and we're working towards expanding that work to kids. We hadn't been doing the PHQ-9 in teenagers like on a regular basis or the ASQ. So I think expanding that work and kind of standardizing it for our 12 and up is the goal for us, so that everybody gets the same screenings.
Wonderful, thank you. And then do we happen to have anyone from Fisher Titus Pediatrics in Norwalk?
Yes, this is Paul Winek, one of 3 pediatricians here. We have been doing depression screening for a little while now, but we have not been doing suicide screening. I think it's very important to do that as well, especially after listening to Dr. Denny. And so we look forward to trying to incorporate that screening in our office practice here. At the end of the project, we hope that will definitely reduce the number of suicide attempts in our area.
Great, thank you so much for joining us. And I will follow up with you to kind of get us caught up, since we haven't had a chance to like formally have our kickoff call. So, but we're so excited to have you. And then Dr. Lazaron and her team at the Christ Hospital.
Hi there, this is David Strawn. I'm an intern in Christ Hospital Family Medicine residency. So intern class, we're passionate about this. This is a really timely issue with the epidemic of gun violence in our country and worsening mental health for our youth throughout the COVID pandemic. So very passionate about it. And overall, just goal is to just get screening and appropriate intervention to be more commonplace and standardized in our clinic.
Wonderful. Well, we're so happy to have all of you. Thank you. Mercy Health Anderson.
Yeah, hi. My name's Wade Rankin. I'm the program director for the residency program here at Mercy Health in Anderson. For our sake, this actually fills 2 needs or requests. One, we have integrated behavioral medicine, and being able to integrate behavioral medicine specialists in our practice even more seamlessly with pediatrics is going to be really important for us. And then the second part is the quality improvement projects that can flow from the work that we're doing to actually educate the residents on how to make dedicated changes to practice that are lasting and mean something. So at the end of the project, we want to be able to basically integrate suicide screening as well as depression screening into every well visit for pediatric patients over the age of 12. So it's a great time for us, and we're really excited to join the program.
Wonderful, thank you. Fisher Titus Family Medicine in Wakeman.
Hi, good afternoon. It's Chris Canfield. We have 3 primary care or family practitioners in our clinic and an APP as well. And I'm actually part of the Fisher Titus Pediatrics and Fisher Titus Medicine Milan. We're all part of one group. And so these other practices decided to come on board. Like just yesterday, I kind of shook and rattled the cage a bit. Interestingly enough, I'm going to be the person who's out there saying that the first reason I looked at this is because I need a QI improvement project for my maintenance of certification for my board status. And I have a student this year in a really novel program where the 3rd year student following with me the entire year. And she also needed a QI improvement project. And this thing just popped up right away. And we both thought this is great, something that's meaningful, because there's nothing worse than doing a meaningless QI improvement project just because you have to. And on a more personal note, a very close family of mine, a family friend of mine had either accidental death or suicide, who knows. He was 12 years old with a handgun just in the last year. So this really hits home. We also are blessed with a community of people who don't see the gun issue as it is, so to speak. And any attempt that we make often is to talk about gun safety. We get a lot of flack from our patients because of the culture of our county. So I'm hoping through this process we can learn some ways to have those discussions in a less threatening manner. We're not taking away your rights to have guns, et cetera. But let's go back and look at the number of children in our community who've died by lethal means in the last couple of years. And, even though we're small, we've got those numbers out there. So what started out to be just, my goodness, I need a quality improvement project, is turning into something that's, really, we've got a lot of our practices on board. They think it's very pertinent. Our community health assessment done by our health department points to suicide as one of our top issues to deal with. So we hope to, at the end of this, absolutely incorporate this as a routine, so that we're paying more attention to this, and hoping to maybe consolidate some of our behavioral health resources in a more organized fashion for our providers. So we appreciate the opportunity to participate in this for multiple reasons.
Wonderful. Thank you. And thank you for rattling the cages. We really appreciate that as well. New Carlyle Family Medicine. I think we may have had an illness there today, so we will move on to Summa Health Barberton.
Hi, I'm John Edwards. We're a family medicine residency training program. I'm actually pinch hitting today. We're blessed to have on our faculty a full-time behavioral health professional who really has a passion for pediatric mental health. And so she was the one that made us aware of this project and has been our champion, but unfortunately she's ill today. I'm going to echo some of what my colleagues said. Part of this was we live in a part of the state where gun ownership is prevalent and part of the culture. And then, I think our primary goal is to make this part of our clinical culture and have people comfortable having the discussions that we've talked about. And then, also to be able to demonstrate both within our institution and to our accrediting bodies that we're about the types of quality improvement and public health interventions that are so critical right now.
Wonderful. Thank you. And hope Karen is feeling better soon.
Thanks.
Lake County Family Practice. I saw a message earlier from Dr. Brown that she may have had a conflict, but I thought that I saw her log in. I will follow up with her. Tri-City Family Medicine.
Hi, this is Jennifer Bacci. There are several of us on today from the Tri-City team. So this came to us from Dr. Carbone, who is a family practice physician in the office here. And he was kind of the one, bringing the whole program forward. So in our area in Lorain County, adolescent suicide is like the second leading cause of death. So that, really hit home for us, which really spearheaded us getting involved in this project. I know we also have our behavioral health specialist on the line. She'll probably want to say something.
Hi, I'm Grace. Yeah, I'm here. I'm the behavioral health coordinator here at Tri-City. I'm here with Dr. Carbone's medical assistant, who's going to be helping with the data collection and things of that nature, Lindsay. Dr. Carbone definitely was very interested the first time he saw this email. He got Jennifer and I involved right away and was ready to get started. Definitely in Lorain County, we have a real issue with adolescent suicide and rates only increasing. So hopefully we can make this a more relevant thing within UH as well. So hopefully, I think I'll go ahead and maybe try and reach out to the ACO and see what we can do, like you mentioned earlier about making this an ongoing thing.
Yes, and we are happy to help you through that process too, and provide information and support for that. And we've got until February to work on sustainability with your practice. So I always say we start working on that like day one. So we're happy to do that.
Thank you so much.
Thank you. And then do we have anyone from Fisher Titus Family Medicine, Milan? Am I saying that correctly?
I think they were unable to join, but they were
Okay.
good to review stuff. Yeah.
All right, wonderful. I will be following up with all of them. Well, thank you all again so much for sharing. You all highlighted like so many of the reasons as we had our intro calls that we talked about. So I appreciate that. And also many of you mentioned something that, again, just to highlight, I know I've shared this with you, but all of your practices actually are located in counties that, based on the data that the Ohio Department of Health has, you have you flag red for suicides in this age population. So we were very happy to work with you and have you interested in doing the project. So I'm going to go through just a few slides You all, except for our new practices, have probably seen the full recruitment packet that goes through the requirements, but I just wanted to review those again and kind of talk about like our immediate next steps. So there is a project intro video. It's about 20 minutes long. It lays some of that background that Dr. Denny mentioned. So we want to have all of your providers having had viewed that by the beginning of September, and most of you have already done that. There is a brief pre-work survey that gives us some additional just basic information and data about your practice. It's done through a SurveyMonkey link, and it's something that usually your office manager or administrator would complete. Again, most of you have done that, but if not, I'll be following up with you to make sure we get that done by the beginning of September. All of the practices, except the new ones, have completed a kickoff meeting. You might remember we talked a lot about the data collection tool and just an overview of the project. We will be having every provider do a very brief, really like a minute long, probably, also through a SurveyMonkey link confidence survey. We'll do that by the end of the month, and then we'll do it again when the project is wrapping up. So I'll be sending you the link for that. We're going to collect some baseline data, and I'll talk more in detail in just a moment about that, but we want to get that all submitted by the end of September. And then there will be practice coaching meetings as we move through the project. I like to joke and say, kind of think of me as your concierge, your practice coach, but I'm here to help you all along through the project, get everything done, answer questions, and then also really learn from you, hear about challenges and obstacles that you face as you do the work, and try to problem solve and help. And again, help us learn what additional resources we need for the project or who we additionally need to reach out to. And then through the months of September through February, that's when we will be looking at your monthly quality improvement data. We'll be sharing that with you, talking about it, making tweaks and changes, and then moving forward. And then the PDSAs that you'll be completing, again, I'll be here to help you complete those and think of topics for those. You will submit those as a clinic. So not every provider will be submitting a PDSA. It will be one for your entire practice. And then action period calls, which is where we all join together. We'll be having those in October, December, and then late January. So before I move on, any questions about the requirements? All right, so baseline data reporting. This is where
unmute quite fast enough. Can you tell me a little bit more about the baseline data?
Yes, I'm going to go. Yep, I'm going to go through that right now. And that's going to be something, again, that I'll be following up with each of you individually to help you get completed. So when you see this, you will start to think about, will our practice really be able to pull this from an EHR report, or will we need to do some chart reviewing to get this? Some of these numbers may be zero for you. So if your baseline data isn't able to be reported from an EHR, that's where we'll have to talk about doing some chart reviewing. And we'll definitely send you all of this in detail and follow up with you. So what we're going to do is look at the months of August, September, October, and November of 2021. So roughly this sort of same beginning time period back last year. Now, one of the things we've talked about in the project is for pediatric practices, this work is going to be done at what we're calling adolescent or youth preventative visits. So well visits or sports physicals. So that's what our baseline data will look at as well. And we're going to want to look in those months for that. And we're separating the ages just because we want to take a look at sort of the younger adolescents versus the older, but how many had a preventative visit that month? Of those visits, how many were screened for depression? Of those visits, how many were screened for suicidality? And of those visits, how many had lethal means storage? So as I mentioned, some of those may be zeros for that baseline data. Any questions about that before I move to family practice? So as Dr. Denny mentioned, one of the things we've heard is that in the family practices, they may not have the volume of preventative visits. So there's been a suggestion that, we actually would like to do the work with every adolescent we see, which we are more than open to. But that's just something that we have to kind of know from your practice and have that be decided. So if in a family practice, you're going to be doing the work in all adolescent visits or youth visits for that age group, then the baseline data has to match that. So we would be looking at, in this age of patients, how many were seen for an appointment during the month, how many of those were screened for depression, how many were screened for suicide, how many had lethal mean storage discussed, and then the same data for the age 17 through 21. I will be sending you a Excel spreadsheet where all of this is defined, all of this is laid out, and you'll just have to put the numbers in for the baseline. And like I said, and then I'll be following up with you with any questions or challenges that you have. So any comments or questions there?
You did say if we were not going to be able to get that out of our EHR, we could just do random audits of 16 charts in that age group.
Yes.
Yeah. Okay.
Yes. Yep. So I will, that'll all be defined out for you so that you have that in hand. And then I mentioned the pre-post confidence survey. So again, that's a very brief, probably like 5-item survey. I'll have that in a SurveyMonkey link, and that's going to be sent out to the project lead and the admin lead. And then you will need to ask that all of your providers complete that by the 31st. So by the end of the month, preferably. And everyone does have to do the pre and the post of this. This is one of our requirements for you to get the MOC credit. So I'll include that in the email that you can let your providers know. And then as we wrap up for today, kind of some immediate next steps to think about. So getting really your process for screenings, the discussions, and completing the data tool. I know we've talked about that in our kickoff meetings, and I'm happy to follow up with you if you're still kind of thinking through that process, but that's really what we want to get sort of solidified before September kind of comes around, which I know is coming quickly. Your resources, safety boxes, those types of things will be arriving for you. Make sure that you respond to my email confirming who the contact is to receive these items and your mailing information. We just want to make sure that they get to you, and so that we have that that mailing address kind of correct. Your first batch will be about 10 safety boxes, and then more will be arriving. The other thing we're going to explore over the first couple months is how often do you actually see someone who needs to lock up medication, so that we could then provide you medication lock boxes or medication locking bags or cable locks or cabinet locks. So we want to be able to, again, respond to needs appropriately. And so if you're seeing that you need resources for medications, we want to have that available and not just have you have to use a gun box for that. So, and then September 1 is really going to be our go date for implementing the new process and flow and really starting the work. And then in the next couple weeks to a month, we will schedule a technical assistance call formally, but certainly if you have questions as we move forward, I'm happy to touch base with you at any time. And also begin working on baseline data reporting, and then have all of your providers complete that pre-program confidence survey. So any questions about that?
If you're in a practice where not all providers want to proceed, is that okay?
That's totally fine. Absolutely. So if we love to have the whole clinic, and often what we find is you may have someone not participating, and then they see some of the, ease of the work or the benefits, and then they would like to join. So, but we're totally fine if it's not every provider in the practice. Just again, I need to make sure my list is clear who is participating and who isn't.
I have a nurse practitioner who is going to go on maternity leave.
Okay.
Hopefully like second week of October, and she's going to be gone through January.
Okay.
So there's not much point in her participating, is there?
Probably not.
Okay.
I mean, I think you could certainly, share information with her so that as she comes back, she's ready to kind of get into it. But otherwise, yeah, I agree with you.
Hi, this is Jennifer again from University Hospitals. If there were any other practices, family practices that wanted to join, is there still time for them to do that if they would decide quickly here?
If they decide quickly, I would say yes. I would really want to get going with them, like, in the next day or so, just so we can get them ready to try to, get going as soon into September as we can.
Okay, because there's a Primary Care Institute meeting on Thursday that I was going to speak to this a little bit, just to see if there would be any other interest.
Yes, wonderful. And please just let me know what you need.
Okay, thank you so much.
Thank you. And
I'm Elizabeth Lazaron. I have a question about the numbers needed to participate. Most all of our interns are being involved in this project, but all of them right now are kind of low volume providers, may only be seeing 25 to 30 patients in a month, of which the number of those that are going to be adolescent are going to be low,
right?
But are committed to reaching out to their colleagues who aren't part of the project to also be working with this, the same thing with them. So they're going to be the kind of leads on that. Is that still going to work even if they may be working with a team that includes 2 other doctors filling in that data and they're the collecting and teaching end of this? We have 30 providers here, so it's a little complex, our location.
Yeah, so I think we knew going into this that, like, you may have, because you do have interns, that some of them won't have a huge volume, but you're doing it kind of across multiple providers, correct?
That's right. So
Yeah,
all providers going to be doing it in the practice, but the interns are going to be the ones who are going to be the project leads to do the PDSAs, right?
Yes, that's totally fine.
Okay, great. Thank you.
A couple of things I wanted to just mention. Dr. Brown isn't able to comment on her reasoning, but it's in the chat if you guys wanted to take a look at that. She answered our kind of intro question in the chat, so thank you. All right, so I think we have a few more minutes. Dr. Gittleman, if there was anything you wanted to follow up with or any additional questions.
No, I just think it's really exciting that it seems like everyone's excited about the project, realizes why it's so important, and I think that we're going to get some good results. So I'm really looking forward to seeing what we get over the next couple of months.
All right. Well, thank you all so much again for taking this on, and we're really excited about all the great work we're going to do over the next several months. So I will be in touch, and just making sure you have the recording from today, the slides, and then, like I said, that we have all those mailing pieces so we can get your boxes shipped out to you. All right. Thanks again.
Thank you.
Thanks. Have a good one.
You all too.